Welcome, everyone. My name is Edith. I am here to kickstart the December, our monthly webinar series that we've been starting since January. This is our 12th and final lecture for the year. We are excited and honored to have Dr. Nicole Plenty with us today on a very important topic since IIH really targets women. And this is women's health. IIH and pregnancy combined is an incredible topic, a lot of interest in this topic. And we're delighted to have you today. Dr. Plenty is a double board certified OBGYN and maternal-fetal medicine physician. She really has been essential and vital to the community. She's very caring and generous, giving webinars, lectures, and has an incredible website we'd love for you guys to check out called Pregnancy Pearls, along with her social media. You can follow her on many platforms. We will have that available for you on our website and at the end of this lecture. And I am going to go ahead and mute myself and allow Dr. Plenty to go ahead and speak. We will have the chat live and open. I will introduce questions to her as we go or hold most of them to the end for a discussion. If everyone could please just go ahead and mute themselves, we can go ahead and start with her lecture.
Well, welcome everyone. Thank you so much, Edith, for the introduction. I really appreciate it. And I appreciate the opportunity to come here and share. Like she said before, I am a maternal-fetal medicine specialist in OBGYN. I practice in Atlanta, Georgia. And most people are like, what exactly is MFM or maternal-fetal medicine? It just means that I, in addition to being an OBGYN, I have a little bit of more training. I'm doing critical care cases and management of complex pregnancies, diagnosis of babies that may have anomalies. And so I take care of a lot of patients that end up having some trouble in pregnancy, which may require hospitalization or may require some close monitoring after delivery. So I take care of a lot of patients with Pseudotumor Cerebri or IIH in pregnancy. Actually pretty common. So there's quite a few people that get referred to me for this reason. Just as in full disclosure, Nishi told you that I have a podcast called Pregnancy Pearls Podcast. It is on a network called Media Online and Media Productions. And so this is not a talk on behalf of them, although they love the fact that I'm giving this talk and have no issues with it. I'm also on the American College of OBGYN's National Board of Directors. And so this is not a talk on their behalf. This is data that is from several international institutions and evidence-based, as well as from my own clinical experience. So just a little background from me, just so you know who I am and who's talking to you, and if you should believe the things that I say or not. I went to undergrad. I'm from Louisiana, a really small town called DeRidder, Louisiana. And after graduating high school, I went to Xavier University of Louisiana, which is in New Orleans. It is a Catholic, historically Black college and institution. After that, I went to Tulane University School of Medicine. Hurricane Katrina hit, and that made me become more interested in public health issues, particularly how public health crises impact pregnancy and health systems. So I do have a master's in public health with a concentration in health systems management and policy. After that, I did my fellowship and residency training at Ole Miss, which is the University of Mississippi Medical Center. After that, I started private practice. I started practice at Community Health Network, which is a private institution, but it's also an academic teaching institution in Indianapolis, Indiana. After a year there, I was forced into medical directorship at that institution, and then left for Houston, where I was a division director of MFM at several hospitals there. One of which, the main one I served in is Methodist Hospital, which is in Katy, Texas, which is a suburb of Houston. And then the Women's Hospital of Texas, which is a major institution in Houston that delivers about 12,000 babies a year. And now I'm at Wellstar Health System, which is the bottom image that you see there, which is in Atlanta, Georgia. It's one of the biggest health systems in Georgia. I am based in the Marietta location, although we will be expanding to other locations in the next month. So what we're going to do today is we're going to talk about IIH and how it affects pregnancy. We're going to discuss the management of IIH during the pregnancy, and then we'll discuss some postpartum considerations related to IIH. And then I am going to answer your questions. But before I start, I just want to make sure we understand that I consider this a safe space. Like, we are all family here. And so if you have any questions, please don't wait until the end. Raise your hand or send a note to Edith and say, hey, I have a question, because I want to make sure that I'm clarifying things as I go. Sometimes it's easier to clarify things as you go, as opposed to trying to remember exactly what you said before. So if you have questions, feel free to ask them during the discussion. Let's start at least with the case, because at that point, you can at least see the case that we will talk about as the common presentation that I've had for patients that have had IIH. So I apologize for that, you guys, but thank you guys for stopping me before we got too far into this. So this is a 30-year-old who is in her second pregnancy. She's had one full-term pregnancy. She's 31 weeks pregnant now, and she has more frequent headaches. She previously had headaches before pregnancy, but now her headaches are more frequent. She describes her headaches as a throbbing sensation behind her eyes. She has known Pseudotumor Cerebri, but is not on any medication since becoming pregnant. She was referred to me for further management and treatment. This is a pretty common scenario with patients with IIH, that one, they discontinue all of their medicines when they get pregnant. And two, they just sort of think they should grin and bear it, right? They should just grin and bear it and go through the pregnancy. So let's talk about IIH. I know you guys know what these are, but just in case there are clinicians that are listening that are here to learn and don't treat this commonly, IIH is basically a buildup of pressure, intracranial pressure. And because you have intracranial pressure that's built up, it's going to present with signs and symptoms of intracranial pressure, such as a headache. Usually that headache is in a pulsatile fashion, like it was in this case that we just presented. And usually people can also have nausea and vomiting, dizziness, and it can even affect vision. Now, the most common sign that we see clinically is papilledema, okay? So I'll talk about the difference between the symptoms and the signs. So obviously the signs as clinicians, what we look for, the symptoms are going to be what your patient feels. And headache is going to be the most common symptom. And this could remain even after you have relief of the high intracranial pressure. So how do we diagnose it? Usually it's with a lumbar puncture. So if you have an LP that's an opening pressure over 250 millimeters of water, this is diagnostic of IIH. And an LP can be done during the pregnancy. So if you have somebody that has frequent headaches before pregnancy, you are getting a workup done before pregnancy, but you haven't quite diagnosed it. That patient is still having issues with a headache during the pregnancy. You can do an LP during the pregnancy, which can be diagnostic and therapeutic as well. The thing that I will caution clinicians about is fluoroscopy. So some people do their lumbar punctures under fluoro because it's better to see to illuminate the spinal canal. But fluoroscopy in the first trimester has been associated with some birth defects, okay? Because that causes a high amount of radiation, and fluoro specifically has been linked to having babies that have an increased risk of heart defects in the first trimester. So if we can avoid fluoro in the first trimester, you should. But again, you can do an LP without going under fluoro. So symptoms that patients have with papilledema, which is the most common sign, is going to be a headache. And that headache is usually worse in the morning. People can have nausea and vomiting, transient visual disturbances. Some patients have a swooshing sound in their head, tinnitus or ringing of the ears, diplopia or double vision, and then a blind spot in the vision with enlargement. Signs, you can have normal or decreased visual acuity when you're doing a visual acuity test. Some people have decreased color vision seen with color vision testing. When we look at the back of the optic disc, you can have blurred disc margins. You can also have optic nerve hyperemia, or we have more sort of redness and dilation of your optic nerve. Some people have disc hemorrhage, which we look for as cotton wool spots, and then patent lines that we can see when we're looking at the back of the retina. And with the blind spot enlargement, we can see atrophy or pallor there. So when we talk about treatment for IIH, a lot of people try not to treat people with IIH in pregnancy, and that is absolutely wrong. There's absolutely no reason people in pregnancy should suffer from constant headaches. The treatment goal is so we can relieve the pressure in the brain and preserve vision, because obviously if you have more and more intracranial pressure, which is putting more pressure on your optic nerve, that can be detrimental and can lead to issues with vision and blindness. So we want to make sure that patients are being monitored very closely during the pregnancy, and that we're doing things to preserve vision and relieve symptoms, particularly the symptoms of a headache. Symptoms of a headache tell us something is still going on. We still have increased intracranial pressure there that we need to address. And so the treatment goal is to preserve vision and relieve symptoms, particularly the symptom of a headache, because that's the telltale sign that we monitor for during the pregnancy. Now, pregnant women should be managed and treated the same as people that are not pregnant, with a few exceptions that we'll get into. So for the most part, if you were doing something before pregnancy for management and it worked, usually we continue that during the pregnancy unless you're on medications that are contraindicated. So anybody that has IIH during the pregnancy, I would recommend a preconception consultation with your OBGYN or someone that does high-risk pregnancies, like a maternal-fetal medicine specialist like myself, so that we can go through all of your treatment regimen to make sure you are on stuff that is safe in pregnancy. And the reason this is really crucial is people with IIH present in the childbearing years. These are people that are 18 to 35 that usually present and get diagnosed with IIH. Well, those are usually the times that people are getting pregnant. And so we want to make sure that any treatment that people get, whether you're planning for pregnancy or not, they honestly should all be pregnancy safe, because anyone can get pregnant in those crucial years that are the vital times of diagnosis of IIH. So let me stop there. I see that there's some there's stuff in the chat. I see 10 chats. Edith, are we okay with questions?
Yes, it was just introducing and introductions, and that the slides weren't working earlier.
Gotcha. So somebody was actually looking out for me and telling me the slides weren't working. Thank you guys so much.
Yes.
All right, so treatment. The main treatment in pregnancy and outside of pregnancy are going to be your carbonic anhydrase inhibitors. That's going to be acetazolamide or Diamox. If you have IIH, I know that you've heard of this drug. We prescribe it in divided doses of 1 milligram. So you may be on 0.5 milligrams twice a day, or you may be on 0.5 milligrams 3 times a day, or up to 2 grams over several doses. Usually once we're getting up to 2 grams, if that's not working, then we're usually trying something else. Acetazolamide is going to function by decreasing the cerebral spinal fluid production, okay? And so if your body is not churning out as much cerebral spinal fluid, the theory is you won't have as much pressure on the brain and the spinal cord. So then you won't have as much papilledema or pressure on your optic nerve, and then you won't have as many headaches. So Diamox is used pretty commonly to treat IIH in and out of pregnancy. Some people may also need pain medication I do not recommend pain medicine as first line, which is why I did not put it on this slide. People that have migraines that are not thought to be IIH may be on pain medication like a Norco or a Percocet. But in pregnancy, we don't want to use those things long term because babies that are born to moms that are on long-term narcotics can have an increased risk of what's called neonatal abstinence syndrome or symptoms of withdrawal from that narcotic. And so if we have to use pain medicines, I ask my patients to use it sparingly, like only as needed. Will you take Percocet or Norco on top of your Diamox? Because if your Diamox isn't working, that means that we need to increase the dose of that Diamox, or we need to do something else. If a patient has rapidly progressing vision loss, but doesn't have really a lot of headache, then optic nerve fenestration is what needs to happen as a surgical treatment of choice. You can do optic nerve fenestration if you need to in pregnancy. And ACOG, or the American College of OBGYNs, actually recommends this treatment modality over diversion surgeries, which I'll talk about in a second. But you can have optic nerve fenestration in pregnancy because what we don't want to do is not treat you and then you have some permanent vision loss there, okay? And so in order to know this, your OBGYN would be needing to co-manage you with a neurologist so that your neurologist will be monitoring your a neurologist and or an ophthalmologist will be monitoring you for signs of papilledema and nerve damage, and your ophthalmologist will be looking at the retina, monitoring for signs of increased intraocular pressure to know, hey, you're having more vision loss. We're seeing that your visual field acuity is decreasing. Maybe you need an optic nerve sheath fenestration. This is extremely rare in pregnancy. I've actually only had 2 patients that have needed optic nerve sheath fenestration during the pregnancy. Majority of people can be treated with just acetazolamide and Diamox alone. Now, patients with vision loss, papilledema, and a headache that don't respond to medical therapy, like we've done Diamox, we've increased the doses of Diamox, we've also given you intermittent narcotics, that's not working, then a CSF diversion procedure is the preferred treatment. But this is only if absolutely necessary, because this is like a shunt, right? So we're placing a shunt, or a neurosurgery is placing a shunt, which then goes in the abdomen. Cerebral spinal fluid then drains into the abdomen. Well, obviously, we don't want to do anything abdominally that can, interfere with the pregnancy. Obviously, the shunt's not going into the uterus, and obviously we don't have to make an incision on your uterus or interrupt the pregnancy. But anytime we have an abdominal surgery, that can potentially cause palpation of the uterus or manipulation of the uterus, which can then cause contractions, which can put somebody at increased risk of going into preterm labor. So that's why we don't do the CSF diversion procedure unless you absolutely need it, right? Because we don't want permanent vision loss. And so we absolutely need it. Patients can get that. But like I say, most patients respond very well to Diamox if they continue it during their pregnancy. Other pregnancy considerations. I don't know if he's told you guys I'm getting over laryngitis, so bear with me. So co-management should be between an OBGYN, a maternal-fetal medicine specialist, a neurologist, and likely an ophthalmologist if there's issues with papilledema. All patients in pregnancy do get detailed ultrasounds around 18 to 20 weeks, so we can look at the baby from head to toe to see if there's anything going on with the baby, okay? And I say that because Diamox is well studied in pregnancy, but there are some studies that say, hey, babies that are born to moms that are on Diamox can have an increased risk of being smaller. And animal studies have shown that some of those babies have an increased risk of some defects, specifically spinal cord defects. So we want to make sure that moms do get a detailed ultrasound. Those studies in humans are not consistent as those in animals. And so I do recommend continuation of Diamox if a patient is on Diamox and needs Diamox in the pregnancy. Now, if a person got a preconception consultation and they did not have headaches, they were treated well with Diamox, and we can wean that and see if that helps, or if they've already had an optic nerve fenestration before pregnancy and they're asymptomatic, but their clinician has them on Diamox just as maintenance. We will see if we can wean that off, see if it can help. But if you haven't been weaned off of it before the pregnancy, and you're weaned off of it at the beginning of pregnancy, and you start to have issues with symptoms of increased intracranial pressure, i.e. headaches that are more frequent and pulsatile, then I would recommend continuing on that through the pregnancy. Now, once the patient reaches viability, which depends on where you are and where you practice, but where I practice, viability is 22 weeks and 5 days. Internationally, 23 weeks has been known to be sort of the cutoff of when patients are viable, when they're not. So that 23-week and 500-gram weight of a baby is usually when a baby is big enough to intervene and for us to intubate a baby to help a baby breathe. So once somebody reaches 23 weeks and 500 grams, then we will be doing growth scans serially to look at the size of the baby, because again, Diamox in itself can put a baby at increased risk of being smaller. People with IIH in general also can have an increased risk of having a preterm birth and having a smaller baby. So we want to monitor you through the pregnancy. But for the most part, people with IIH do very well, and their pregnancy outcomes are generally the same as people that don't have IIH. So other comments, and I say this because I've seen crazy things, and I feel like I need to put it out there so people can know and advocate for themselves. Some people think because you have IIH, you can't have an epidural. That is not true. You can have an epidural, okay? Actually, it probably will help with your headache. So you can have an epidural. Patients can deliver vaginally. People think because you're pushing, that may put too much intracranial pressure and cause you to have issues with worsening visual acuity. That's usually generally not the case. There's a couple of exceptions to that. Meaning if a patient needed a diversion surgery because they had such high intracranial pressure that they're having visual loss, and they refuse to do it during the pregnancy, which means that your intracranial pressure is high, then you may need what's called an operative vaginal delivery, meaning once your baby is complete and crowning, we may need to do something like a vacuum assistance, meaning it's like a little suction we put on the baby's head, and then we help you by pulling the baby down the birth canal or back down into the vagina and out while you are pushing, so that you don't have to exert as much intracranial pressure. The other alternative is to go straight to C-section so that you won't push at all. But that's only with people that have extremely severe intracranial pressure, signs and symptoms of papilledema with evidence of vision loss. Those are usually the only people that cannot deliver vaginally. Of course, if you have other reasons for needing a vaginal a C-section, like you've already had a C-section before, or if you have had a myomectomy or any surgeries on your uterus, then obviously those are reasons that you may need a C-section. But if you don't have anything else going on and you have IIH, you can deliver vaginally unless, like I say, it's an extreme case. The visual outcomes are actually the same during pregnancy as they are when you're not pregnant. Okay, so pregnancy is not going to worsen the progression of visual loss in people with IIH. That is not true. They usually do the same. So if you had worsening visual acuity before pregnancy, it's going to progress during pregnancy. So it's better to get a preconception consultation and get that treated before pregnancy if possible. And then the rate of miscarriage is not increased with IIH. People with IIH have the same rate of miscarriage as people without IIH. This does not increase your risk of a poor pregnancy outcome related to stillbirth or miscarriage. So if we circle back to the case, and then I'll go to questions after that. In this patient that is 31 weeks pregnant, who presented with more frequent headaches, who previously had headaches before the pregnancy, stopped her Diamox. What should happen with this pregnancy is she should be put back on Diamox, okay? So if this patient was sent to me, I would restart her on Diamox. I would start her at the dose that was last effective for her. You know, some clinicians say, well, I don't know where to start. Do I start at the minimal dose or do I start at the highest dose? You start at the last effective dose and then titrate up from there. Let's say a patient is on her last effective dose and it's not working. There's a couple reasons that may be the case. One, the blood doubles in the pregnancy, blood volume doubles in the pregnancy. And so heart function is working more in the pregnancy, and you have more circulation of blood during the pregnancy. And so it's almost like putting a drop of dye into a cup versus a drop of dye into like a gallon bucket. Obviously, red dye in a cup may look like sort of dark pink. Red dye, that same amount of red dye in a gallon is going to look, you know, super light pink, right? It's more diluted. Same thing with certain medicines in pregnancy. You are diluting the drug. So it's very common for us to have to go up on the medication doses during the pregnancy to get the same relief of the headache. This patient also needs every trimester eye exams. So she needs eye exams through an ophthalmologist to look for evidence of papilledema, to look at the back of the retina, retinopathy, and to look for signs of decreased visual acuity. We'll also center for co-management with a neurologist, which is a doctor that treats headaches, so that we can get her on the right regimen. And if a patient does need breakthrough pain medicine like a narcotic, I would want that managed with a neurologist, if possible, so that we can make sure that we're treating the patient on the right amount of stuff. I know some people have asked me, said, hey, I was on Toradol before pregnancy. Can I take that with IIH during pregnancy? I would caution against something like Toradol. Toradol is an NSAID, a non-steroidal anti-inflammatory. There is a role for NSAIDs in IIH, but that role is just patchwork, right? It's decreasing inflammation, yes, but it doesn't decrease the intracranial pressure. So it's not going to give us much relief as something like acetazolamide. And so I would recommend that over something like a Toradol or an NSAID. Additionally, NSAIDs in the third trimester should be used with caution. They can inadvertently close one of the shunts in the baby's heart called the patent ductus arteriosus. Closure of that prematurely can lead to pulmonary hypertension or high blood pressure in the lungs of the baby. That can be life-threatening and also have some long-term complications. So we do not like to use Motrins or Toradol or Tramadols in pregnancy if we can avoid them, especially beyond the 32nd week. Let me stop there, Edith, and ask if anyone has any questions.
Yes, we do. We have a couple of great questions. Thank you for breaking for us. So one question is, would the pushing time during labor need to be decreased in someone who has IIH?
So no. So the pushing time is going to depend on the parity, if you will, of the patient. So if a patient does not have an epidural, according to American College of OBGYNs, they are still on the normal labor curve. If they are a primate or if it's their first baby, they can push for up to 4 hours with no epidural, 3 hours with one. If it is their second or more baby, they can push up to 3 hours or 2 without. So you don't have to say, oh, no, you can only push for an hour, you can only push for 2 hours because we're going to increase your intracranial pressure. That's not true. We do not change the rules for people with IIH, okay? We don't change the rules. So the pushing time is the same, either 3 or 4 hours.
Wonderful. I think that is actually awesome that people can still have a normal pregnancy. And I'm assuming, and the other question to that was, if they have manifestation of papilledema, would that also play a role in the pushing, or it's the same statement you made?
So it plays a role in the pushing if it's extreme. So if you have somebody that has papilledema and evidence of severe increased intracranial pressure, then we say, hey, this is a person that needs intervention before they deliver. Okay, so either that person needs optic fenestration surgery before they deliver if it's severe, or if it's not severe and there's evidence of mild papilledema, then perhaps they need the adjustment of their acetazolamide dose. But we don't not allow them to push. What we would do is offer them an operative vaginal delivery so that they're not exerting as much pressure intracranially. So we would be doing either a forceps delivery or a vacuum delivery to try to assist with delivery of the baby, meaning putting traction on the baby's head while the mom pushes so that she will not exert as much intracranial pressure. Those are also people that I would say, hey, an epidural could relieve some of that intracranial pressure. And usually we do see that happens with people with IIH. They actually feel a lot better in labor when they actually get an epidural, because some of that cerebral spinal fluid is going to drip out when they place the epidural. And so some people do get a little bit of relief just by the spinal or the epidural. But if a person has severe papilledema, then the duration is not the concern. We let them labor down, but it is the pulling. And if we are doing an assisted vaginal delivery, meaning a forceps or a vacuum vaginal delivery, then usually the time is shorter, because once the head is engaged and we can see the head at +1 station, meaning you can see the head without spreading the labia, then we can apply the vacuum or the forceps and go ahead and assist that mom in delivering. That does shorten the second stage just by doing an operative delivery.
Wonderful, thank you. And another question, we have a provider that does not always have access to MRI or specialists for advice or to make the diagnosis. Are clinical signs enough to start treatment with Diamox?
So I get, it depends on the clinician, right? So if you are a clinician and you are taking care of pregnant women, and let's say you're family medicine, if you feel comfortable managing somebody in pregnancy and starting Diamox, then yes, clinically you can make a diagnosis of IIH and start them on a trial of Diamox in the pregnancy. Yes, but I would caution, if you're somebody that is a mid-level provider and your collaborating clinician or physician doesn't feel comfortable with it, then I would recommend referring that patient to a neurologist or a maternal-fetal medicine specialist that can touch and agree with you and start that patient on something. So it's a really touchy subject when you talk about counseling a patient on the risk and being able to follow those adverse side effects of Diamox, because Diamox can have some side effects. Like some people have like a weird taste in their mouth. Some people have dizziness just with Diamox. If it's decreasing your intracranial pressure, some people can feel like sort of woozy. So we need to make sure we're managing the side effects of Diamox as well. And if you have a clinician that doesn't do an LP, can't do LP, and can't refer out to do an LP, but they feel comfortable counseling a patient on the risk and monitoring that, then yes, that you could start a trial of Diamox. But I would caution, if you don't feel comfortable counseling about those risks in the pregnancy, then refer them out, have somebody formulate a plan that you can follow, and then have them referred back.
Wonderful. Thank you. Actually, the attendee who asked this question is actually a physician doing mission work as a humanitarian doctor in Africa. So she definitely does not have the resources, to probably get someone as specialized as you, unless you do telemedicine, then.
Well, I do good telemedicine, but I will say this: if you're doing mission work and you got a patient that you say, this person has all the clinical signs of IIH. They're having headaches, they're pulsatile, they're throbbing. It's not like she's having 1 or 2 headaches a month. She's having headaches every single day. She's had it since before she got pregnant, or even if she's not pregnant, then yeah, I would start them on a trial of Diamox. Absolutely. Because what you don't want to do is not start anything and then all of a sudden you have decreased visual acuity. So I would definitely agree with you of starting a trial, for sure.
Thank you very much. And Barack, I think you have a question for Dr. Plenty.
Yeah, I do. I was wondering, Dr. Plenty, if obviously you're talking a lot as a physician treating individual patients, but you also are an MPH. And I was wondering if you have any thoughts on IIH from a public health perspective, how we can perhaps deal with it differently, et cetera.
I think that from a public health perspective, IIH, like a lot of other diseases that affect women, it's just not amplified enough, right? So I think that having people utilize their platforms like you guys are doing is great, but I think we do need to do some social media campaigns. I think we do need to do some more awareness, because half the battle is that people never heard of it, right? They've never heard of IIH. I have patients that come to me that have frequent headaches, and I ask them specifically, have you ever been told you have pseudotumor cerebri? And they say, I didn't know what that is. Or intracranial, idiopathic intracranial hypertension. They're like, no, I've never heard of that. So some of this is just public awareness. I think we could work with our health departments to get some of that information out. But I think it has to start with our providers and our clinicians, because we have providers and clinicians, honestly, that this is not even on the forefront of their minds to even screen for this condition. So I think this starts with family practitioners first, internal medicine physicians first, because those are the people that are doing wellness exams. And people that have IIH definitely have these symptoms before pregnancy. It's just that they happen to get pregnant and then they find somebody and they're like, we're working up a headache, and hey, you don't fit the clinical criteria for anything in pregnancy. Let's figure out if you have IIH. So from a public health standpoint, I think that there needs to be more funding invested into public health campaigns and awareness, because this is not hard to diagnose. It's not hard to start somebody on a clinical trial of medications. But I think that there's just not enough awareness. So
do you think that the epidemiology, I can't remember the number, but it's like 2 or 3 per 100,000. Do you think the numbers are undercounted?
Oh yeah. I mean, 2 to 15% of people with IIH and pregnancy are going to have an issue. Like 15% are going to need some type of treatment. That's a lot of people. I think that it's definitely underdiagnosed. I think a lot of people probably have mild IIH and they just have been dealing with it and don't know it, because if you don't really complain about things a lot, and if it's your norm, it's sort of like it's normal for me. Like I ask a patient, like, hey, are you having any headaches? Not any more abnormal than I usually have. I'm like, well, tell me what you usually have, And because people are used to just grinning and bearing it and going on. So I would definitely encourage patients, if you have a headache more than about once every couple of weeks is not normal. It's just not. Like, you should not be living your life with headaches. Like, I get a headache maybe every month. I get a headache because I'm tired or I'm sick. But people with IIH are getting headaches a couple times a week. That's not normal. So I think that it's definitely underdiagnosed because it's a woman's disease. And women honestly don't complain as much as men. I hate to say it, Barack, but we don't complain as much. And because we don't complain as much, we sort of grin and bear it. It's like, oh, it's normal for us. So Yeah, I do think it's underdiagnosed for sure.
My wife would say that I complain a lot. I have a quick final question, and that is, we're so often hearing that IIH is first diagnosed at an ophthalmologist or even an optometrist or
An eye doctor, somebody that does eyes.
yeah. And but it sounds like, given what you've just been saying and this lack of awareness and the underdiagnosed nature, you yourself, like someone's coming for maternal care, your colleagues are often finding it. Is that true?
That's very true. So yeah, it is often diagnosed at an ophthalmologist's office because people that are getting eye exams, they're looking at their optic disc and saying, whoa, your optic disc are blurred. Wait a minute, what's going on? Are you having headaches? And then they're like, okay, you have blurred optic disc. This goes with IIH. And so this is what we suspect. Then they get referred to a neurologist that does an LP. They find the opening pressures over 250 and they say, okay, this is now diagnostic and consistent, right? But if you have the symptomatology that says you're having frequent pulsatile headaches, if that headache, to the point of the physician that is in Africa, if you start that person on trial Diamox and it helps, then we know that you have IIH, right? Because why else would you be relieved with decreased intracranial pressure? So then you have to think about the population of people that actually go to an ophthalmologist. You know, people that go to ophthalmologists are already having issues with visual acuity. That's why they're going to the eye doctor. They're having issues with visual acuity, and then they're linking that visual acuity to IIH. But there are a lot of people that have IIH and headaches before they have issues with their visual acuity. And that's why it's underdiagnosed. It's diagnosed later if they're waiting for an ophthalmologist. And if they have frequent headaches and they're complaining enough, then they're getting seen by a neurologist who's going straight to an LP. So there's a lot of reasons this is undiagnosed. A lot of people have health insurance and don't have vision insurance. They're not paying for that. And so they're not going to an ophthalmologist. There are a lot of people that need glasses that don't wear them because they've never had an eye test. So yes, clinicians are diagnosing this because of the symptomatology and then referring to neurology. Then they get referred to ophthalmology. That's usually my workaround. I refer to neurology. Neurology refers to ophtho, which then surpasses the need for like the vision insurance that you would need to do ophthalmology.
Thank you.
Of course. Edith, any other questions?
I don't see any other questions unless I'm wrong. Anyone can feel free to unmute and ask Dr. Plenty since we have a few extra minutes.
So let me go backwards just a little bit because I know that we talked about neurology versus ophthalmology and who is diagnosing this. And I think that this is really important. If you are practicing in an area that's rural and you don't have subspecialists, but you do think that a patient meets criteria for IIH, I do think it's very reasonable to treat them with Diamox because Diamox is cheap and usually it's accessible. And to the point of Barack, if you're waiting to have visual acuity changes to be seen by an ophthalmologist, that may mean that you have progressive IIH, which can cause some long-lasting and long-sustaining issues with vision. So I would encourage patients that if you have headaches specifically, I think anybody with a headache that's not relieved with typical over-the-counter medicines, if you're needing to be treated with narcotics for headaches, they should be at least diagnosed with, they should be at least worked up for IIH before they're started down this pathway of chronic pain when we can do something to just relieve the cerebrospinal fluid. The other thing that's important, which I don't know how I missed this slide in here, is headaches in pregnancy. Headaches are really common with people that have IIH, and the goal is to treat patients until they don't have a headache as early in the pregnancy as possible. Once we get into the third trimester or even the late second trimester, it can be really confusing between IIH and other reasons people have headaches in pregnancy. Preeclampsia, which is when you have a headache and protein in your urine, or symptom of a headache. You can also have blurry vision. And you can also have pain up here at the top over your liver, right upper quadrant pain, plus elevated blood pressure, plus abnormal labs, which we look for as protein in your urine. You can also have evidence of liver damage and kidney damage. Preeclampsia can have symptoms that look just like IIH. A headache that's unrelieved with Tylenol and blurry vision. What do people have with IIH? Double vision, headaches that are pulsatile in fashion, and guess what? They're not relieved with Tylenol. So it's really important for us to get somebody on a treatment regimen early in the pregnancy as possible so that we won't be confusing IIH and preeclampsia, because if a person gets referred to neurology with a headache, 9 times out of 10, they're going to say this headache is due to preeclampsia. Even if the patient has completely normal blood pressures, I have to call them back and say, try again. This is not what it is. But it does confuse the clinical picture. The difference between a headache that's caused by something like preeclampsia and a headache that's caused by IIH is that preeclampsia has to have high blood pressure. IIH has high intracranial pressure, but usually does not present with high blood pressure. Now, people that have IIH do have a higher likelihood of having chronic hypertension, meaning high blood pressure outside of pregnancy. Why is that? Some people with IIH, when we look at the characteristics of patients, they can be overweight. People that are overweight have a higher risk of chronic hypertension, but the two don't go the same, okay? So people that don't have chronic hypertension, meaning high blood pressure outside of pregnancy, if you have IIH, you should not be presenting with high blood pressure. So if a patient has a headache, all of a sudden, and they have IIH, but they were controlled on their Diamox or whatever the regimen was they were on, and now they have a headache despite that regimen, I'm going to work them up for preeclampsia. So I'm going to look at lab work to look at the kidneys and the liver and protein in your urine. And if any of those labs are significantly elevated, then I know that you have preeclampsia. Preeclampsia, we try to conservatively manage, meaning keep a patient pregnant. If you have severe range blood pressures or severe features of preeclampsia, like a headache or lab abnormalities, then we try to treat that acutely, meaning we try to give you blood pressure medicines, get your blood pressures under control, and we try to relieve your headache. And if we can do that, if you're before 34 weeks pregnant, we try to get you to 34 weeks and then deliver you. If you're beyond 34 weeks and you have severe range blood pressures at any time, even if they're treated, or lab abnormalities, then you're delivered at that time. For patients that have an unrelenting headache that are diagnosed with preeclampsia or symptoms, blurry vision that's persistent, pain in over their liver, then they get delivered. It doesn't matter if they're 24 or 25 weeks. People with IIH don't get delivered, okay? Delivery can cause you to have some relief of intracranial pressure just because your intra-abdominal pressure can play a role on your intracranial pressure. And so delivering you can cause you to have a little bit of relief, but usually it's not significant. And so delivery is not recommended early for patients with IIH because it's not going to help that headache. You still have a headache after you deliver. So the treatment would be go ahead and do the LP, go ahead and increase the Diamox, go ahead and do the surgical treatment and keep the patient pregnant. So the headache can confuse things, okay? Most common reason for a headache in pregnancy is just because of hormonal changes. But we're talking about pathological issues. It's preeclampsia. It's way more common than IIH. And so people are always going to be pushing for, hey, preeclampsia means delivery. But we do not want to deliver patients prematurely if we don't have to, if the headache is just because of IIH. So the telltale sign is going to be they have high blood pressure associated with the headache, or they don't have high blood pressure associated with the headache. That's going to be the deciding factor. Any other questions?
I do actually have one more, sorry.
Okay.
Just since we have a tiny bit more time, this may be less about pregnancy, so I'm not sure if you're fully comfortable answering it, and just say, but when you were talking earlier about headaches in general, it does, and how they're so often misunderstood. It seems like there's the general headache that you talked about that Tylenol will take care of. There's a lot of awareness of that.
Yep.
And then there's the other type of a headache that has a ton of awareness in the world, which is migraine. And I'm wondering how many headaches, or if some percentage of headaches that are considered to be migraine are actually IIH, or are they driven, or are there distinctive differences that you can talk about that could help people say it's one or the other?
So realistically, the workup of a headache, right? If you have a headache, there are different types of headaches. So some people have cluster headaches, some people have tension headaches, some people have migraines. So depending on the location that you have the headache, the characteristic of the headache, and the frequency of the headache, whether or not you have aura or not, I mean, you have a funny taste in your mouth, you have a funny smell, that tells a clinician, hey, what type of headache does this person have, and whether or not this is a migraine. But in the workup of a headache, if they give you a trial of medicine and you're relieved, then we know that that's usually not IIH. In the workup of a migraine, usually people have unrelenting headaches with the typical medication used to treat headaches. So NSAIDs usually. So you get no relief with Tylenol, you get no relief with Motrin, you get no relief with Toradol or Tramadol. And so then we're looking at, hey, is this a migraine? And usually migraines can be associated with some things. Some people have photosensitivity, people have associated nausea and vomiting, people have aura, meaning they can have funny tastes and smells. Usually we see that typical with a migraine. Now, the workup for a migraine usually excludes, meaning rules out IIH. So if you go to a neurologist and they're working for a migraine, they usually are going to do an LP and also recommend an eye exam. If you have a thorough workup and you've actually been diagnosed with a migraine, they've ruled out IIH as the etiology of your migraine-like symptom. Okay, so a lot of people say, I have a migraine because they've heard somebody else have a migraine or they've read about migraines, but they haven't been formally diagnosed with a migraine. So a lot of patients say they have migraines, but they've never been formally diagnosed. And so that population that has not been formally diagnosed means they have not had an eye exam and have not had an LP to rule out IIH. Yeah, there's a subset of those that probably do have IIH. I particularly don't know the percentage of those people that have not been diagnosed with IIH that actually have been inadvertently told they have migraines, but I'm sure that you probably have a large pool of people that assume they have migraines that don't.
Thank you very much for answering all of our questions. I would like to take a second, if I can, to share my screen. Oh, it's not letting me. That's okay. I wanted to share with the audience your beautiful website, Pregnancy Pearls. It is literally a wealth of information for everyone. It has lots of great topics, ways to contact you if they want to see you as a patient. And how I found you, just a little shout out, you have a podcast called Pregnancy Pearls, and you even had one, it was on season 3, episode 37, Another Cause of Headaches, which was 3 cases that you just really did what you did today. Is when a provider sees a patient, yes, like if you have IIH, you want that to be the forefront, but you really got to exclude some really big things like preeclampsia. And that is the cause of headaches. But like you said, high blood pressure or not. That's very important. And these are the things that go through practitioners and providers and physicians' heads when they meet a patient for the first time is, yeah, we understand you, have a condition or a diagnosis, but let's also, rule out some other, we like to say horses instead of zebras sometimes, rule out the really big ones. But, thank you, Barack, for helping me. So we added on the chat some ways to contact you, some ways we can follow you on your social media. Also on our website, we have a small article featuring you called Pearls of Wisdom for a Safe Pregnancy. And we also, thank you, have you on our practitioners page. So if this was a lot and people can't find you, then you can also visit our website and click on there to find you to see Dr. Plenty as a patient. Thank you so much for rounding out our amazing year of webinars. We really are so grateful to have you come on today. Thank you for what you do for the community and spreading your amazing knowledge to everyone about, high-risk pregnancies and IIH.
Thank you so much for having me. I'm always willing to talk about anything that's going to decrease people's risk in pregnancy. I think that we as women and men that are supporting us need to do whatever we can to keep each other safe. There's no reason to keep this information a secret. And so if I can assist anybody in anything, just give me a holler and let me know. But thank you so much, Edith, for having me. Thank you, Barack, for having me and making sure that my slides were functioning. And I hope everybody has a fantastic holiday season. I love this time of year because we get to be with friends and family. So I hope you guys have a happy holiday.
You too. Thank you so much. And we'll keep in touch.
Absolutely.